Can we see that? Yep. Can we see that, Yazan?
I can see it, yeah.
Fantastic. Right. So, hi everyone. My name is Dominic. I'm infectious diseases and medical microbiology registrar, and we're going to be going through infection for MRCP Part 1 and Part 2. I wanted to just show this because there are some fantastic sample questions as well on the MRCP UK website. There's about 80 of them. It's free to do, and I must admit some of them are quite thought-provoking. So it's quite a useful thing just to kind of help you along, because ID is something that it can be difficult to know what you're going to be asked, and it can be the weird and wonderful. So I think for this lecture, what I've tried to say is there's a lot of infectious diseases, and trying to teach you all of them would be a very difficult thing. So it's best to focus on the high yield topics. So I think these are the ones that we're going to be focusing on kind of today: malaria, dengue, HIV, fluke infections, TB, meningitis and encephalitis, and endocarditis, because I think that gives you a good overview of what we're doing. So the first thing we're going to talk about is malaria. So malaria is one of the most important kind of infectious diseases that we can kind of really consider. And as you can see, it causes a huge amount of disease. There's about 240 million cases in 2020 and about 500,000 deaths associated with that. And the reason I'm bringing it up straight away is because for fever and returning traveler, which is kind of a common question, this makes up about 30% of the diagnosis and is one of the leading, well, actually, it is the leading cause of death in patients who are returning travelers with fever. And the important things that we're going to be going through with malaria is the fact that it is very widespread. So the map, as you can see on the bottom left, just shows the distribution of it. So Africa, certainly, South America, going into Central America and Asia, are all relative kind of hotspots. And the important thing to remember here is obviously that this is a life-threatening disease, but can present fairly innocuously to start off with, often described as a flu-like illness, and then rapidly can become worse, especially with delays in treatment. Now, the little figure that you see on the far right is an algorithm, which I'm sure some of you may recognize. That is the VHF algorithm, so viral hemorrhagic fevers, and that's because any returning traveler should have a VHF assessment. So any person who has traveled from the endemic area within 21 days who has got a fever, you should be doing this, because malaria, yes, there's a very good chance it could be that, but we want to exclude VHFs because very much associated with mortality and very transmissible, not only to you but to other patients. So always make sure you're aware of that, and that helps you to determine whether you need to treat them as high risk or low risk. Anyway, so for malaria, the key things are that there are 5 species. Now, the ones that you need to worry about is by far and away P. falciparum. The reason is that is the one which is very much the most associated with mortality. When you think of the other species like Vivax and Ovale, that is much more associated with morbidity, and that is because they can what we call recrudesce. So you can have infection that you initially treat, and then maybe 2 years down the line, they can pre-present with malaria, and that's because of a unique stage in the malaria infection that those species have. Now, I have put Knowlesi as another one that's ranked within mortality, but this is quite rare and is geographically restricted to parts of Asia. It's actually something you find in monkeys, but certainly falciparum is the one that you need to be worried about. And the incubation period for malaria, so that is the time between exposure and symptoms onset. This is something that ID love to always think about. It can be very short to quite long, so 7 days to 1 month. All right, so it's really important to notice that, so they can be symptomatic very quickly. And actually, I've been dealing most of the afternoon with one. And the suspicion that you should have in the question or anything is somebody's come from an endemic area. So it might be from, for instance, sub-Saharan Africa, where kind of around over 90% of cases can occur, but they've come in with jaundice, a palpable spleen, maybe the stupor, so the GCS is maybe a little bit less, and they're just feeling kind of generally malaised. I would be thinking straight away, what is the risk of malaria? How should we go about testing that? And I've put here for mimic. So, it's, as we've mentioned, VHF is always something that we should consider, but these are other mimics that we kind of think of. So I've put, for instance, leptospirosis. So this is something that's worldwide. It's a spirochete, so it's related to kind of things like syphilis, but it's a bacteria usually found with rodents and urine and can pretty much present like this, but with severe hepatitis, enteric fever, which is a type of salmonella, yellow fever, which you'll pretty much find in South America, but was also spread by mosquitoes, hepatitis. Please always test for Hep B and Hep C, because you'll be amazed how many times you'll pick up that actually that's what they've got, or indeed Hep A or Hep E, because it could be acute. And there are lots of others. Now, the life cycle here is quite complex, and we're not going to focus on it too much, but I think the key points here is it's only female Anopheles mosquitoes that actually spread malaria, and it's not all Anopheles mosquitoes. That's something I really want to make abundantly clear. Anopheles mosquitoes don't send out dengue, and all the other kind of arboviruses. But the main thing is the mosquito is infected. It injects you with sporozoites. These are the kind of agile swimming stage. They infect your liver. And then depending on what malaria you have, if it's 5-Axovali, they can form what we call hypnozoites, which are then sleep and are silent and don't do anything. And that's why you can have infection many years later. But otherwise, they'll burst out from the liver cells and start infecting your red blood cells. And so that's why you get the waves of fevers that are kind of described, because you're getting release of brand new merozoites from infected red blood cells, which then go on to infect more. So you get waves and waves of parasitemia. And as you can tell, that can build up over time. And then some of those kind of merocytes will become gametocytes, and these are what basically go on to form more malaria that is then taken up by the mosquito, and then they're infected. So that's a very short condensed. Now, whenever you're dealing with malaria, the key things you need to differentiate is it uncomplicated or is it complicated? So what we look for is, one of the first things is the parasitemia. So parasitemia is just literally a percentage of blood cells that are infected. So we will generally say anything over 2%, so if it's 3% and above, we would say that's complicated. So this means I'm putting them in a more severe bracket and I'm more concerned. Now, you'll see that I've written things like no schisons or with schisons. So if you look on the far right, you'll see the late schisson stages where you've got lots of these little kind of circles within the red blood cells. So in Falciparum, because of the way that this malaria works versus the other species, you don't usually see these in the blood. If they're in the blood, that's a bad sign. You will see them with other malaria species because they don't stick to the endothelium of blood vessels and sequester into organs. So if you see schisons, that's a very bad sign for Falciparum, and we'll put you straight away in the complicated section. But as you can see, the main ways that we can do it as well is through clinical assessment. So if you're seeing patients with CNS signs, so usually it's stupor, and it's more of an encephalopathy than any kind of encephalitis, severe renal failure, pulmonary edema. So these patients, you don't want to give them lots of fluid. If you see that they're low, you want to kind of give them a 500 ml bolus. You do not give them a litre stat and then followed by another litre, because they'll go into flash pulmonary edema. You want to do your blood sugars, because this will often be low and severe, and look for signs of shock with acidosis. Now, as you can see, a lot of this can be then picked up through using just a venous blood gas, because you can pick up the acidosis, you get an idea of the HB, you can look for the hypoglycemia, and some obviously can give you a rough creatinine. So you can work out quite a lot. Now, in terms of transfusions and things, the only times that we worry about the blood cell anemia is when it's less than 50. So as you can see, you can be quite low before we're getting too worried. But remember, these patients are high risk of coagulopathy and other problems. And hemoglobinuria is why you often get the described kind of black water fever. Okay, so this is where they have literally black urine because of the hemosiderin for the breakdown of red blood cells. So any one of those criteria means they're severe, and that's going to dictate how you treat the patient. Now, obviously, we've made our clinical assessment, but we need to know what to send to diagnose them. So the important thing for your exams and for real life is that thick and thin blood films are the gold standard. It's nothing else. And thick films are about 30 times more sensitive than thin films. The reason that we do them is that the thick film looks for globally is there parasites in the red blood cells. The thin film lets you differentiate the species, because as we said, there's different species. Now, the important thing is, because with Falciparum malaria, it has a particular stickiness that it does to the red blood cells, so they attach to the endothelium of blood vessels. That means that if you do a blood film, you may not actually see anything in the blood film. So there may be no parasites there when you've put your venipuncture into the middle of the vessel. So that's why you can never exclude malaria based on one blood film. So we'll always say you need to do serial blood films, and that'll be one per day. And if you're worried about a patient, we would still treat. And this is why you can discuss with the kind of ID and micro. Now, a lot of you may be aware of rapid diagnostic tests, and these are incredibly useful, but there are problems that you need to know. So the rapid diagnostic test looks for specific kind of antigens associated. So for instance, histidine-rich protein 2. So that's one for kind of falciparum. And they can differentiate species. But there are three things you need to remember. They're not as sensitive as blood films. They rely on detecting antigen, not live parasite. So once you've treated someone for malaria, for instance, the antigen test, the rapid diagnostic test, will still stay positive for up to 2 weeks afterwards. And they can't tell you how many red blood cells are infected. So they can't tell you the parasitemia. So that's why, even if you've got a positive rapid diagnostic test, you need to do the film. Okay. Now, the important thing is because you have infection of red blood cells, they're then bursting, giving you the fevers, and then you're getting infections of other blood cells. These patients can rapidly increase their parasitemia, and they can rapidly worsen in front of your eyes. So over a night shift, they may be very much from not too bad to really needing ITU level support. So you need to rapidly phone the labs, get them to make sure that they know that this sample is coming to test, but also ensure that there's proper escalation pathways present. Now, if you've got somebody who's got complicated therapy, we want to give artesunate. So artesunate kind of works at all stages of the malaria parasite. It is something that's very well tolerated, and we give it at fixed doses. So as I've written here, you kind of give it 0, 12, and 24 hours, and then daily thereafter. Okay. If you're asked between artesunate and quinine, IV quinine is not very well handled. It causes hyperglycemias, QT syndromes, tinnitus. Often patients will have blurred vision. It's very poorly, and it's inferior to artesunate. So always artesunate first. If you don't have it, then it would be kind of quinine. The important thing I will mention is for artesunate is that after you've given some treatment for malaria with artesunate, they can develop hemolysis up to 2 weeks and actually up to 4 weeks after treatment. So you have to monitor the full blood count. So that's a very good question they can ask. What side effect would you be worried about with artesunate? Delayed hemolysis. I'm going to repeat a blood film 2 weeks after their treatment. Now, if they have got complicated therapy, so you've given them their artesunate, they're doing well, you're doing repeat blood counts and blood films, and you see the parasitemia is going down, you then give them a full course of what we call artemisinin combination therapy. So this is where we have two drugs, one which involves the kind of artemisins and one which involves kind of a typical antimalarial, which is not artemether kind of based. So for instance, this one here, Riomet, is artemether and lumefantrine. And the whole point is the artemether gobbles up a lot of and takes away a lot of the malaria, and the lumefantrine is protected from being resistant because the artemether's already wiped away a lot of the parasites, and then the lumefantrine's mopping up. So you're protecting the second drug. So you'll give them a full course of ACT, so as I said, artemisinin combination therapy. For uncomplicated, though, you can use Riomet, and that's completely fine. All right. One thing that and that would be kind of a normal 3-day therapy, and then you would just be monitoring the parasitemia throughout that. Now, chloroquine, you can use chloroquine in P. falciparum, but only in like areas of the Panama Canal. So never suggest that in your answer because you're almost undoubtedly going to be wrong. If there's any signs of concern, we should be using artesunate as said. And it's always important to make sure that people are aware that malaria, if you've had it, you're not immune to it. And people who are born in malaria endemic areas do have some immunity, but that's lost within about 6 months of moving. So if they go back to an area, so they go back home, for instance, to South Africa, then they're not protected. They need prophylaxis. So when you're seeing a patient in the ED who you think might have malaria, but they tell you from prophylaxis, please make sure that you've asked them about their compliance with it, because sometimes it's been suboptimal. The thing I want to talk about next is dengue. So the reason we're talking about dengue is because, so this is a flavivirus. This is also spread by mosquitoes, but this is by different species. So instead of Anopheles, we have the Aedes aegypti and the Aedes albopictus. And this is what we can see here, the Aedes albopictus. You can always tell the difference between the mosquitoes if anyone's interested, because the Anopheles has its bottom in the air, whereas the Aedes doesn't. As you can see, its body is flat towards the surface and is quite pretty. But the point is, dengue is expanding. And as you can see from the map on the right, these are endemic areas of dengue. And actually, this map is even a little bit delayed because we know that it's already present within parts of France and northern France. It has been seen in Spain and lots of different areas of Europe now, and actually there are about 400 million cases each year, so it's spread to all pretty much continents, and it's a big concern. Importantly, with dengue, the things to know is that it has a very short incubation period. So it can be, we usually say 4 to 7 days, but it can be up to 10 days. And most people, when they're exposed to dengue, aren't sick. So they don't get really any symptoms. But 1 in 4 will. And these symptoms often can present on a spectrum, just like anything. So classical symptoms that should make you think of dengue after traveling or coming from a kind of at-risk area would be things such as severe myalgia, retroorbital eye pain, and this is something that is kind of classical, and you'll often see in other conditions, particularly viral hemorrhagic fevers, but also things like leptospirosis. Patients can have things like diarrhea, and as mentioned, kind of fever, and typically the fever can be very, very raised, over 40 degrees, and patients may have some lymphadenopathy that you notice as well. Now, in terms of how they can present, so as I said, they can present with these early symptoms, usually very severe myalgias, so they're kind of laying down, they don't want to move, everything hurts. But the rash, as you can see here, is kind of distinctive because it's a fine rash, and particularly on dark skin, it can be very hard to appreciate. But when you press on it, you can leave marks, and that's a very characteristic rash that you'll see. Now, the times that we get worried, and these would be worrying signs, and where you would classify them as having kind of complicated dengue or dengue hemorrhagic fever, is when they start to develop kind of platelet drops. So when the platelets are less than 100, this is why this is a time that we kind of worry and are concerned. And also then where we get the hematocrit starts to rise, usually by 10%. And this is because we are now getting kind of permeability of the blood vessels. So you're now losing fluid and so hemoconcentrating. So this is a bad sign and is suggesting that, especially if you've gotten the presence of effusions, that you are now actually going through the kind of hemorrhagic stage, and now your cardiovascular system is going to really fall apart, and you're going to move into dengue hemorrhagic shock syndrome. So this is where now the blood pressure, as you can imagine, is kind of systolic less than 90, and these patients can be very, very, very poorly. And obviously there is not an insignificant mortality then as soon as you start to progress into the hemorrhagic fever and the shock syndrome. Now, with dengue, much like a lot of the other flaviviruses, so that includes things like Zika, chikungunya, and all the rest of it, they can cause multi-system disease. So obviously inflammation of the endothelium, but you can get encephalitis and you can get myocarditis. Now, in terms of treatment, it's supportive. So we give rigorous kind of fluids because what you don't want is that hemoconcentration, as you mentioned, in the shock. You don't want to give NSAIDs because they do worsen outcomes. So we don't give ibuprofen, but it's fine to give things such as paracetamol and judicious fluids. So it's about monitoring all their losses and giving them there, because what we don't want to do is give them so much fluid now that actually they start to develop all the pericardial effusion, pleural effusion, ascites that we're worried about. Now, in terms of your diagnostics, it depends at the stage that you've presented and the duration of illness. So if you have, 5 days of symptom onset, then generally we can do reverse transcriptase, PCR from the blood, and actually that should be positive. But as you can see, it can be negative quite quickly. So after 5 days, then we'll expect to see serology start to rise, and this is roughly around the kind of 5-day mark. But the important thing to always remember, especially with these type of viruses, is the fact that there can be cross-reactivity. So dengue, if you've had, for instance, yellow fever vaccine and things like that, another flavivirus, then you may cross-react with dengue. So you always have to take this into account. What have they had in terms of vaccinations could give me false positives. But certainly if you've got the impression of this and these clinical findings, you'd want to do that. And the important thing once they recover is talking about the risks of reinfection. So dengue is 4 different viruses, and once you get infected by one, you're immune to that type. But that doesn't mean you can't get dengue from, subtype 2. Okay. And the risk, the thing that we worry about is something called antibody-dependent enhancement. So this is where you have non-neutralizing antibody to the current virus or the current antigen. And so what you get is increased kind of uptake by macrophages and a kind of macrophage activation syndrome. So you get this huge cytokine storm. So when you've got a patient who's had dengue, you have to warn them that when they return to an endemic area, there is a risk, not huge, but about 4% risk, that they could have on second exposure to dengue with a different strain, severe disease where they move into fever and shock. Okay, so that's always something to mention, and that's why I've mentioned the dengue vaccine. So there is a dengue vaccine which we give to patients who have already had dengue once, and then we have proven dengue, and then we give it to them, the vaccine, which then is there to kind of reduce the chances of that occurring. So it has about 80% effectiveness and is 3 doses over a 12-month period. So
Dom,
next we're going to,
can you
yeah.
just press the hide button on the Zoom is sharing your screen? Just
Oh,
that's okay.
sorry.
There you go.
Cheers. So next we're going to talk about HIV. So this is probably bread and butter for ID, and it's something that you can very well get a question on. So as we know, this is a retrovirus, so it has the ability to kind of change RNA to DNA. This is kind of unique, and then integrate it into the genome, and that's the main problem why you can't cure HIV, because it's integrated. There's a reservoir pool, and so if you stop therapy, it will just restart copying, and then we get the problem. Now, this is still a major problem. There's there's the 39 million people worldwide who have HIV. About 37.5 of those are adults, and there's about 1.5 million new cases each year. And as written here, there were 4,000 new diagnoses of HIV in the UK in 2022. And the reason why it's important to know about HIV is because even of those cases, 44% of those were what we call late diagnoses. So this is where the CD4 count is already less than 350. So there's been significant changes to the immune system and kind of attrition of your immune system, where they are now at risk of things like opportunistic infections. So when we're thinking about HIV risk, obviously you might think of things like sub-Saharan Africa and they've been born in Asia and things, but obviously you would want to think about patients who have, for instance, positive syphilis serology, or they've got gonorrhea, chlamydia, you would want to test, or TB, because we know if you have HIV and you have TB, then your TB is much more likely to be difficult to treat and is much more likely to be extrapulmonary, and there are drug-to-drug interactions. So when we think about our high-risk groups, these are the ones that we kind of think of, areas of high prevalence. So this is why in places like London, there's high, you'll often find that in the A&E, they're tested, MSM, so men who have sex with men, sex workers, people who inject drugs, but as you can see, prisoners, and this is often something that's missed, multiple sexual partners. And one thing I haven't mentioned here is people who are existingly on PrEP. So if you're on pre-exposure prophylaxis for HIV, they should be having routinely kind of 3 monthly HIV checks, because obviously they're at higher risk. And it's important to remember the treatments that we give HIV aren't going to protect you from other STIs. So when we're thinking of indicator conditions on AIDS defining conditions, that's really important to know what we're looking for, what we're testing. So here is from BEVA, so that's the British HIV Association. So these are AIDS defining conditions. So if you have this in the presence of HIV, AIDS, you have AIDS. And these are the kind of conditions that should make you consider testing for HIV. And some of them might be, a bit surprising. So cervical cancer, for instance, very common. We've probably all seen a patient or two with that. Non-Hodgkin's lymphoma, definitely. TB is up there, so every TB should be having that. But ones that might surprise is things like pneumonia. If you have recurrent pneumonia, 2 or more episodes in 12 months, they should be going for a HIV test. So it's really important to remember that. Other ones will sound more familiar, so things like pneumocystis carinii, pneumocystis jirovecii, so a fungal infection, which we see different fungal infections here, but things as well like chronic diarrhea, so cryptosporidium, which is not uncommon, found in cows, cattle, and when ingested can cause diarrhea and very severe diarrhea in those who are immune suppressed. But so these are AIDS defining conditions. And what they BEVA kind of say is things that should make you think about offering a HIV test, which for ID, we do it for pretty much everyone. Unexplained leukopenia, so if they've got lymphopenia over 4 weeks, an EBV-like illness, because that would be particularly suggestive of things such as whether they're seroconverting illness, chickenpox or recurrent shingles, for instance, and disseminated. So if they've got, for instance, disseminated shingles, or they've got, for instance, signs of vis-a-vis encephalitis, unexplained oral candida with no plausible kind of cause, because remember your T cells are very important for fungi, Guillain-Barré, candidemia, and chronic diarrhea. And these two pictures here are showing some common things, and I've certainly had patients where this has been missed, and so we've diagnosed them later with advanced HIV. But this is oral hairy leukoplakia, so this is EBV related. So this is lytic EBV, so not latent, it's now lytic and active. And as you can see, it's very well demarcated borders. This is an indicator condition for testing for HIV, certainly. And on here is Kaposi sarcoma, so these violaceous nodules and violaceous lesions that you would test for HHV8, which is uncommon otherwise in people here in the UK, but very common otherwise in places like Africa, where you can get endemic Kaposi's as well. So in terms of the diagnostics, and testing, so we know who we should test, but how do you test them? So it's all about knowing the different types of tests and window periods. And simply put, the window period is the time taken from your exposure to a positive test. Now, that's drastically improved from first generation tests, and I'm not going to focus on first and second generation because we don't use them. So for our kind of fourth generation, which is the one which now all of your HIV tests that you do are, these are where we're looking for the immune response or an antibody to HIV itself, but also looking for antigens. So we're looking for the P24 antigen, which is part of the core structure of HIV. So as you can see here, what we're saying is that the window period is 45 days. So at the end of 45 days, so you would say that we would have picked up 100% of infections. In reality, the actual median time that 99% of infections will be picked up by fourth generation is roughly about 18 days. So you can see it's roughly about 2 weeks. But that's why we counsel patients about the things that you need to maybe repeat the HIV test based on the last sexual exposure or the last indicated exposure that you've picked up, whether that's a needle stick, a blood transfusion, or, as we said, unprotected sexual intercourse. Things like a point of care test have much longer because this is just a rapid IgG screening. And so we will say around 90 days for that. Now, the thing we're going to just talk about briefly is just about the dynamics of HIV infection. So as we can see here, once you get exposed to HIV, normally what will happen is that you don't have much of a viral load, as you can imagine. The first place that it's starting to affect is your lymphoid organs, and that's really kind of your gastrointestinal lymphoid tissue, so your GALT, and your mucosal associated lymphoid tissue, so your MALTs. And this is because you've got lots and lots of T cells and lymphocytes, and remember, because just like with any immune response, it's your antigen presenting cells that then move towards a lymphoid organ. So they move there, and that's where they form the reservoir. So they can spread rapidly to infect loads and loads of lymphocytes. And in primary HIV, so this is the seroconverting illness, which occurs in about 60%, this is where you can get very rapid rises in the HIV titers because we get explosive growth of HIV in terms of RNA copies. And as you can see from the symptoms on the left here in the box, these are very similar to kind of an EBV-like illness. I've got sore throat, I feel myalgic, arthralgic, may have a faint rash, I'm having fever. And then rarely we will see people who will develop things like cranial nerve palsies, meningitis. And the important thing to note is during this rapid replication of the HIV is that because it's affecting your lymphoid cells and your T cells, you can get a rapid reduction in your T cells. So the blue line here shows it's dropped kind of substantially. And that's why rarely you can even get patients with opportunistic infections in primary HIV in their seroconverting illness because you've got this massive kind of decrease in your T cells. What will eventually happen, because remember, HIV is affecting not only T cells, but macrophages, dendritic cells, B cells, is that you basically reach a steady point. And this is where we get this length of time here where your thymus and your bone marrow are spewing out T cells to try and combat this. You're making lots of antibody to try and react to the different envelopes of HIVs, which are mutating constantly to try and clear the virus. And so you eventually you reach this kind of set point. But just like anything, eventually the body kind of gives up, not only because with time, The thymus obviously produces ST cells, and you're getting less antigen presentation from your kind of dendritic cells, which are also being affected, but your bone marrow is being exhausted, and now you're moving towards senescence. So at this point now, the CD4 counts go less and the HIV can take off. And that's why if you leave it untreated, by about 8 years, most patients are kind of dead, or they will start to show opportunistic disease and death will quickly follow. Now, depending on the history that you got for the patient, if they've from sub-Saharan Africa with HIV and you've picked them up kind of very early on, you've caught them up here where the CD4 counts is relatively okay, actually, things are okay, then you might do a very limited screen. But if you've got somebody who's all the way down here with very low CD4 counts, they're less than kind of 200, where we're very worried, where they're now in AIDS, then anything is fair game. So they can have multiple conditions. So this is not only viral reactivation, but signs of parasites, fungal infections. And so this is why we'll do extensive testing. And you may need to do things like lumbar puncture and particular things you would worry about, if somebody's got neurology, which is subacute, and ring-enhancing lesions like toxoplasmosis, if they've come from sub-Saharan Africa and they've got chronic meningitis with high pressures when you do the lumbar puncture, cryptococcal meningitis. So it really changes based on the picture. Now, in terms of your treatment, the treatment of HIV is you start it as soon as possible. You no longer wait now until the CD4 count is less than 350 or anything else. You can even start it same day. So what we do is we always ask ourselves, how bad is the CD4 count and have they got any opportunistic infections? If they've got serious bacterial infection or opportunistic infections, you want to start the HIV within 2 weeks of specific therapy. So I want to make that clear. So if you've got an opportunistic infection like PCP or whatever not, you're going to want to start the PCP treatment and then within 2 weeks then start. So you don't start the HIV treatment first, you start that. Now there are some nuances, things like TB, you may wait up until 4 weeks unless the CD4 count is less than 50. So you would wait a longer time, and the same with cryptococcal meningitis. You want to start specific therapy for those and then do that. Now, in terms of before sending for and starting treatment, you want to send a HIV resistance panel. Why? Because we don't know where they've got that. We need to find out what's from. Is there any resistance to any of the therapies that we're going to start? Remember, we can start therapy for different areas of the life cycle, whether that's the reverse transcriptase, the most common bit that we do, integration, so integrase inhibitors, or if it's even kind of the budding and release of the virions. So we'll often screen them for other infections, as we've said, and then we need to think about particular comorbidities. So for instance, abacavir, which is something that is not as kind of commonly used anymore, is with cardiovascular disease. We need to think about drug interactions. So if we found that they've got TB, you'd want to be very careful about things such as rifampicin. And as we talk about here, this is the kind of usual regime that we'll do. So 2 kind of NRTIs, nucleoside reverse transcriptase inhibitors, and dolutegravir, which is an integrase inhibitor. And we want to do genetic testing. So we do a HLA B5701. So this is looking for hypersensitivity to abacavir. Okay. Now, the important thing I want to just put through, because it might come up as a question, is the fact that if you've got somebody with severe HIV, their CD4 counts are low, and you start putting them on HIV treatment, you can get this immune reconstitution inflammatory syndrome. So this is where now you're starting treatment, the HIV load is going less, the immune system is starting to wake up. And because previously there wasn't enough of an immune system to respond to different antigens, it didn't do anything. Now that you've started to give a bit of life back into the immune system, it's reacting to everything. So patients can get paradoxically worse when you start them on treatment, particularly in the setting of things like TB. So lymph nodes may, for instance, start to swell considerably. Okay. And the end result of what we're trying to achieve is that their HIV viral load is undetectable. Okay. And we would expect that to be roughly kind of at 3 months, that they should be undetectable at the therapy. And if they're undetectable, they can't, they're untransmittable. They can't give it to a partner. But we say that that they don't need to worry about transmitting when they have 2 negative results at 6 months. And these are some other things that you should think about in terms of kind of testing. Now, in terms of virological failure, we roughly say that over 200 copies per mil. So it's not a very high viral load, because you can have people who are in the billions. So if you're on treatment and you start to get 200 copies of a mil, over 200, that's what we call a failure, which means actually they're probably not compliant to treatment, which you need over 95%. We need to do resistance testing and we need to change things up. If it's between 50 and 200, you might not be as worried. That's a low level of viremia. Particularly then if it becomes undetectable afterwards. But anything over 200 is a concern. Now, you may see here about injectables, and we've probably all heard about them. So these are present, but they're not something that you would start somebody off on with HIV. They've been trialed, particularly in patients who are undetectable viral loads to begin with, okay? But they have good evidence, and they involve two agents, ribavirin, which is a protease inhibitor, so that's what breaks down the polyprotein of the HIV into the different proteins, and then the cabotegravir, which is an integrase inhibitor. So they're injectables bi-monthly, and there is some good evidence for them, but certainly things that need to be worked out. Now, an important question as well is about vaccinations. These patients with HIV are less responsive to vaccines and at more risk of vaccine preventable diseases. So key thing, if you're asked, you should never give them, it doesn't matter at what stage of the HIV, if they're undetectable, whatever, never give them the BCG vaccine because they can develop live disease. So don't do it. And then live vaccines, you should not give if the CD4 count is less than 200. If it's not, then you can. So that includes things like, for instance, your mumps, measles, rubella, your VZV. But these are things that we check for in terms of your antibody response before, for treatment to see, do we need to vaccinate you going forward? And these are some of the regimes kind of here with some specific details of what you'll be looking for. So i.e., is there any bone disease and renal disease, for instance, if you're using kind of TDF or TAF, okay? So these are the different treatments. So next we're going to talk about fluke infections. So flukes are flatworms, okay? So the reason we're talking about worms is because if you're coming from abroad or even parts of the UK, you can be infected with worms. And as we can see kind of in this lower list, they can occupy different areas of the body. So liver, so these are 3 species. Fasciola, for instance, is in the UK. Blood from schistosomiasis that we'll talk about. Intestine, fasciolopsis, that we won't focus much on. And then lung, which is a good one to know about. And the key things here is that with worm infections, what you're kind of looking for is sonophilia. Not always, you might not always see it, but usually there's a good going sonophilia. Kind of symptoms such as migratory rashes and problems with maybe kind of asthma-like sounding symptoms, so kind of wheeze and dry cough, and this is because of the migration of the worms throughout the body, because they all go through the lungs and then go to their final destination. And what you want to think about is these kind of questions in your history. So if in the kind of vignette they've said they've had freshwater exposure, I'm thinking of schistosomiasis. If they've eaten things like bear, boar, or pork, and they've come in with swollen eyes and muscle aches, and they're eosinophilic, I'd be thinking about trichinolosis, which is something that you get from these things. If you're walking barefoot on soils and beaches and you come out with a rash above, this rash is kind of larva migrans, and this is a very classic kind of sign of hookworm infections. These are nematodes that will travel through the kind of sand and soil as larvae penetrate the skin, and they cause this kind of serpinguinous or snake-like lesions. But also you'd be thinking of strongyloides, and then fish, crab, and salad, because we'd be wondering about specific things. So fish and crab are going to go through with these flukes, but for instance, salad, you might think of Angiostrongylis, which is certainly a cause of eosinophilic meningitis. Now, the important things for all of these is that realistically, they all require snails as a host, and they all can be treated with praziquantel. Usually 1 dose, but some may need more doses, except for fasciola, which we give another anti-helminthic agent. So for the liver flukes, just to start off with, so these are flukes that you usually have eaten them either from undercooked fish, or you've eaten them maybe from like a sushi preparation, or you've got them from eating kind of wild plants, so watercress or kind of chad if you're in kind of Africa, which is kind of a stimulant plant. So when you're looking for the history, is you look for the exposures. So the classical areas for this are kind of areas of Asia, Russia. So Asia, certainly for Clonorchis, which is one of these liver flukes that will kind of very happily live within your biliary tract. And then we have things like Opisthochus, which is in Russia. And then we have the fasciolas. And as you can see, there's very different exposures. So whether or not you've eaten raw fish, undercooked fish or the wild watercress, but they usually take about 4 weeks to cause symptoms. And you should be suspicious of liver flukes if the patient's got sonophilia, they've got jaundice, hepatomegaly, they may have some diarrhea, and they may describe to you some odd symptoms of sometimes I see some kind of migratory kind of rash that's over my tummy. The important point here is that the liver flukes will cause and give you issues of cholangitis because they occupy the biliary tree and they can block it. So if you block any fluid in the body, it can become infected because obviously there's bugs there, you're interfering with it. And so you can get bacterial cholangitis, which is a complication of a worm. So this picture at the bottom right is actually a case where somebody came in with obstructive jaundice, thought to be cholangitis, noticed to be sonophilia, and what they find is a rather beautiful worm of fasciola in there. And classical and kind of findings that you would expect to see is kind of floating worms on the ultrasound when you're looking for the ducts, or diffuse dilatation, because obviously the worms are swimming along and laying eggs, which you'll pick up then in the stool, but also on things like CT and MRIs, which are increasingly being used, kind of paths through the liver because they start swimming actually into the parenchyma of the liver and coming back out. And the reason we care about these is twofold. When some of the worms die, they can form biliary stones, which is then going to give you more signs of obstructive jaundice, but they can cause as well biliary cancer. So clonorchis, for instance, which is common in China, Thailand and things, these are very much associated with biliary cancer, and so it's a huge risk factor. So that's why we'd like to treat. And as we've said, we can treat very easily because we can give things such as prazoquintal. So that's liver flukes. Schistosomiasis then is something that I'm sure everyone's heard about just to some degree, even from the good old med school days and maybe even clinical practice. The key thing is this is a neglected tropical disease with about 200 million cases worldwide and affects, you'll get it from South America to kind of Indonesia and China to, kind of all the way to South America. So it's very widely spread. And as I've said with the others, they all involve the snail as an intermediate host. And that's the ones that will affect us. So it's our exposure to fresh water with snails that have then been kind of infected with Miracidia, and then they send out the free swimming cercary or parasites that then penetrate through our skin and give us the problems. So these are the main ones that we worry about: Mansoni hematobium intercalatum. And we also think of japonicum, particularly in Asia. So Japan for japonicum. It's always good to know. Now, the important things here is that there are multiple hosts. So even though the snail is the intermediate, you can get, it's not baboons with Mansoni and cattle, for instance. But they're not a significant way that you get the actual disease. And you don't get the disease from eating a snail, just to make that clear. It's because the cercary released in the fresh water have penetrated. So fishermen, people who have been running around in lakes, for instance, will get this. And that's why we can get a spectrum of disease from no symptoms, and then we pick it up asymptomatically through serology, or they can have kind of acute disease or chronic disease, which you're probably aware of in terms of things such as portal hypertension, maybe fibrosis of the bowel, or kind of cirrhosis and problems like that. And this is a little bit about the life cycle, which I'll happily go through if anybody has questions later. Now, in terms of the symptoms, it really depends what's kind of happening. So if I'm exposed to the schistosoma, the incubation period is between 2 to 9 weeks. And we can get two different things. So we can either be kind of relatively asymptomatic. So I've been infected. The eggs are now, we form the adults, they're going to start forming eggs, and then that really just carries on. And I don't really notice much. Or you can have kind of acute symptoms. So this is what we call the kind of Katayama fever. So the Katayama fever is typically an allergic kind of reaction, if you will, where you are now having a reaction to pretty much the first eggs that are being made. And you don't make eggs in acute schistosomal infection for about kind of a month to 8 weeks after you've been infected. Yeah. So you've been infected, 8 weeks later, you'll start making the eggs, and the eggs are giving you a bit of jip. So you're starting to become you're having an allergic reaction to them, and so you get these hepatosplenomegaly, very dry cough, because as you get the migration, just like any other worm, they actually do migrate through the through the lungs as well. So you get granulomas and things in the lungs with schisto, and you get these fevers and myalgias. And so this is the time that you would treat a little bit differently from chronic kind of schistosomiasis. And this here on the kind of top right is the kind of swimmer's itch that you may have also heard from acute infection. And this is where you have kind of on exposure where the cerci have penetrated the skin, these kind of very kind of itchy circular lesions, often seen on the kind of legs, around the kind of your bottom half of the body. But this is a kind of hypersensitivity reaction that should raise suspicion. Now, in terms of the chronic infection, well, once you're infected, you start forming the eggs, and the eggs, depending on the different worm types, will occupy different spaces. So Mansoni and Japonicum, they, as you know, occupy the mesenteric veins. So they start producing eggs into the eroding through into the bowel lumen, which then goes out into the stool. So that's why we check the stools for them. Whereas hematobium is through the urine. So through chronic infection, what will happen is that you will get those kind of symptoms. So diarrhea, maybe blood in the stool. You will eventually, because if you imagine you're passing the egg through, it's inflammation, you can get strictures and fibrosis, and there is risks with things such as colon cancer as well. But you will get kind of fistulas and protein losing enteropathy. And this can go on for years before somebody has actually detected this. So they could have been exposed 30 years ago while they were living there. The important thing is that the eggs, when they're going around, even though we say, oh, they'll end up in the urine or the stool, they can end up pretty much anywhere. So it's not actually that uncommon for them to move into kind of CNS. And so cases of neurology and transverse myelitis certainly have been well described in the literature with this. So you can get neurology. Now, the important thing for you to remember is that with kind of chronic infection, the risks are cirrhosis and portal hypertension. And that's because some of the eggs will get stuck where the bowel is, or the bladder, for instance, is fibrosed. They can't penetrate through the backflow of the blood. They'll end up in the liver and they form granulomas, increasing resistance and portal resistance, and therefore causing portal hypertension. So cirrhosis, certainly. But the key thing I want you to remember is SCC of the bladder, particularly for schistosoma hematobium. So that's the big complication that you want to avert. And as you can see on this X-ray, with chronic inflammation, what you get sclerosis or calcification, and that's why you get this calcified bladder. So if you see that, this sounds like schistosomiasis to me. So in terms of how you diagnose, it depends where we're at. So if you've got acute Katayama fever, even though you're producing the eggs, we don't expect to find them in the stool or the urine. They're probably just burrowing their way through. They may be in very low concentrations. So actually, that's a clinical diagnosis, which is how we would treat them with praziquantel and also with steroids. And you would actually repeat the treatment of praziquantel 6 to 8 weeks later to cover new eggs that are being produced. Otherwise, how you will treat it depends on how they've really presented. So you typically, if it's a returning traveler, for instance, or somebody I was born in sub-Saharan Africa and I've moved, you would want to do serology. And we can, so you can do an ELISA, so just a serum sample, and we can test you and we can see the strength of the reaction, simply put. And if that's positive, we would offer treatment. Obviously, in your clinical assessment, you'll be looking for symptoms. So have you got blood in the stools? Have you got blood in the urine? What symptoms are present? But we also can do then, to work out the type of schistosoma, the actual OCP, so ovices and parasites in the stool. And we differentiate the different schistosoma species by where the spines are. So if there's no spines, then it's hepatobium and intercalatum. If it's lateral, it's Mansoni on the egg. And and that's how we kind of do that. Otherwise, we do for hematobium, you will do kind of urine. You will do terminal urine collections. And so basically that means the last kind of little bit of pee for 24 hours, you collect in a bottle, and then we spin that down and check for it. So once you've diagnosed it, praziquantel is the therapy, and there isn't really any kind of praziquantel resistance that you need to be worried about for now. The next type I want to talk about is lung flukes. So the reason I mention this is because this is what you can get from eating undercooked crab, for instance, and this is not uncommon, for instance, in Thailand and different areas, and this is very widespread. So from Scandinavia all the way to West Africa, Mexico, and the Far East. So there are different, what we call paragonomyosis, different kind of paragonomal infections. And the important reason I mention this is because this is a differential for TB. So the patients often present with a cavitation or a fluid-filled cystic cavity, might be very much in the middle lobe or upper lobe, which we'll talk about very like that. But they look too well for TB. They're not they're not actually that bad, and they've got rusty sputum more than anything else. And they also describe some fever, some diarrhea, and maybe some odd, as I say, rashes across the abdomen, because how it gets into the lung is through traveling through your diaphragm and then going up. So if you get these features, this is something that you would think of. And what we would do for these is certainly, yes, you would, if the question says we test ZN staining of the sputum as negative, what else could it be? Paragangliomyces certainly would be up there for me. And this is the one that we would treat for a little bit longer. So while the others are usually 1 to 2 doses, we usually give this over 3 days instead. So this is an important one. So this comes on quite nicely then to TB. So TB, leading cause of kind of death. It's a global problem. And the important thing I want to get on board, because I think it's missed clinically, is that if you've been exposed to TB and latent TB, you may reactivate 50, 60 years later. So when we're talking about travel history, that's why we talk about where have you been kind of things and family history, because you might have been exposed then, it's latent, and then many, many years later, it comes back to haunt you. And as you can see, so far in 2023, there's been about 2,000 notifications of TB. And these are the risk factors that make me think. So, if there's a family history, they've come from an endemic country, or they've stayed there for long periods of time. So maybe you did, I don't know, long-term travel, silicosis, because it damages your macrophages, IV drug use, prison stay, etc. But this, I think, is important. So if you're exposed to TB, you don't invariably get it. About 70% will clear it. 30% of them will have primary TB. So this is where now it's starting to replicate. It's in your macrophages. It's down kind of trodding your kind of your phagosome lysosome fusion and your reaction oxygen species. And then what will happen is one of two things. You either become latent infection, so we can't eradicate the TB, but we kind of hone it off and try to form these granulomas, or you go primary progressive. And this is where now you're starting to have the kind of miliary TB. So the important thing here is that if you have latent TB, your lifetime risk of reactivating is up to 10% in your lifetime. So at any point. If you have HIV, however, then the risk of you reactivating your latent TB is about 20 times that risk. So that's why we always test for them in one another. Now, in terms of the symptoms and the diagnostics, the important thing to remember for TB is it can affect every single organ. There is not one organ it can't affect, one system it can't affect. And as we keep saying, the importance of testing for HIV is not only to predict whether you might become from latent to active, but also because it predicts whether you have more severe disease and extrapulmonary disease, so CNS disease and other areas. And remember, intestinal TB is a differential for IBD, and I've seen a few in clinic that have been missed, where it's not IBD, it's actually TB. So the important things here, and I'm not going to labor on it, is that that for pulmonary disease, the symptoms are usually fevers, night sweats, hemoptysis often. The patients will have lymphadenopathy, and often there's, kind of this quite stark unintentional weight loss that the patients kind of will present with. And when you're kind of seeing that, you need to, as we said, look for the epidemiological exposure, okay? And assess then for extrapulmonary disease. So the commonest are lymphatic, so checking lymph nodes, and this is why often people will have scans to look for spread. So common ones are obviously spreading to lymph nodes, but also pleura, adrenal glands. It's a very common cause of adrenal insufficiency, or can be. GU, so genitourinary, is not uncommon, and CNS. So you look for CNS symptoms and things like that. But the important thing is that you don't rush with treatment. So, for instance, if you've got somebody who's got this type of picture where they've got a very nice cavitating lesion with consolidation, if you start rapidly treating as a cap and you start giving them certain antibiotics, whether that's kind of levo or you give them meropenem, you have to remember some antibiotics actually have TB activity. So you may actually kind of start breeding resistance and actually not helping the problem. So the point is you want to do timely investigations. So the ones that we kind of do, 3 early morning sputums, because that's when the load is highest. At least one of them should be early morning. The other 2 don't necessarily have to be. Blood cultures, which you can do mycobacterial blood cultures, particularly if you've got somebody who's got primary progressive. So this is the miliary TB. So now it's spread and they're spreading through the blood. So we can pick that up. You want to think about getting deeper samples. So bronchoalveolar lavage is not common, and our respiratory physicians are very helpful with that. CT tap, as I said, to find other areas that could be present. And while we're doing kind of early morning sputums to look for TB, which we'll do through kind of staining, we can do molecular tests of the gene expert. So this is something that looks for rifampicin and isoniazid resistance, well, actually particularly rifampicin resistance, which is the most important drug that we have for kind of TB, but it can make the diagnosis as well and has about a sensitivity of about 95%. And is very, very useful because A, it detects a resistance. So you know straight away it's rifampicin, and you know they got TB, and the turnaround can be as little as kind of 24 hours. So it's much better than cultures, which can take far, far longer. And then you might do things like quantiferin and mannitol, but that depends on whether you've had, for instance, the BCG vaccine. So, you know, if you've had the BCG vaccine, you probably might want to do the quantiferin more. Doesn't mean you can't do the mannitol, but you probably want to do quantiferin. And if they're very immune suppressed, you might do things like T-spots. So this is where we're testing whether your immune cells have come into contact and they recognize peptides of TB, and then assess for neurology, because in TB, kind of CNS disease, often the patients have chronic symptoms, chronic headache. They might have signs of hydrocephalus. They'll have kind of cranial nerve palsies, and often they're just not thriving. So in terms of once we've kind of made a diagnosis of TB, then the question is about treatment. So the treatment is based on confirmation and drug sensitivities. You don't want to necessarily rush in. You may have to, but you want to know, is there any risk factors for multi-drug resistance and extreme drug resistance TB? So the things that I would be worried about is if they've had previous treatment, if they've had poor adherence to the previous treatment, if they come from high burden countries. So these are the ones that Eastern Europe, particularly things like Russia, Ukraine, Nigeria, South Africa, certainly Pakistan, Bangladesh. And MDR-TB, we say, is resistance to at least isoniazid and rifampicin, whereas XDR-TB, we say, is resistant to kind of second agents as well. So that includes fluoroquinolones, such as levofloxacin, and these are one injectable. So these are aminoglycosides, amikacin, kanamycin, bedaquiline, or linezolid. So these would never be suggested for you to kind of prescribe. This would be usually in part of a MDT. And the treatment here is intensive and maintenance. So it doesn't matter what you have, whether it's CNS TB, kind of spinal TB and Pott's disease or whatever, there's an intensive phase and a maintenance phase. Kind of for pulmonary disease, as you're, I don't know why I put 2 and 4, so you're going to give 2 4 months. But you may give increased kind of durations, for instance, in pulmonary disease, if they've got, for instance, cavitations, or they have decreased time to make them sputum clear. So to make it clear, just one thing was, you might have heard people say he's smear positive for TB. So all that means is when we've taken your sputum and we looked under the microscope and added the stain, we can see acid fast bacilli. Those patients are way, way, way more infectious than anybody else. So that's, for those patients, that's why you're worried and you put them in a negative pressure room and they're not allowed to come out until they've had 2 weeks of treatment and 3 negative sputums 48 hours apart. Whereas if you're not smear positive, you're less infectious. That doesn't mean you're not infectious. And certainly you'll be worried about patients who've been exposed for maybe kind of 10 hours in the vicinity, for instance. But otherwise, they can just be, you know, if they're tolerating the meds and they're in the room, then actually 2 weeks of treatment and they're well, they can come out and start going back home for the rest of their treatment. So in terms of, with pulmonary, we give kind of RIPE, so rifampicin, isoniazid, pyrazinamide, ethambutol. Important to remember, RAP are the ones that go through the liver, so they cause, that's how they're metabolized. So hepatitis is the big thing, was ethambutol goes through the kidneys as a metabolized. And we will change this in accordance for kind of CNS involvement. And the reason we say that is because for better penetration, we want to use things such as usually floxacin, so moxifloxacin, levo, and we might change for some of these other agents. I realize I put pyrazinamide twice. The important thing as well with CNS disease is that you might want to consider steroids. So steroids are indicated in CNS TB, where they do much more good if you're HIV negative for CNS TB than HIV positive. But ones that, and groups that we worry about, as I said, is where they're very comorbid because interactions with rifampicin. So remember your kind of it's not O devices, it's PC bras and that mnemonic for induction of different things, so including OCPs and pregnancy, because we don't want to use certain of these TB ones, such as pyrazinamide, for instance. And then treatment failure is where we get progressive real symptoms, no real improvement after 2 months of therapy. So that's the kind of induction phase, or there's radiographic worsening and not resolution, or persistent positive sputum cultures. Now, in terms of side effects, these are the kind of key ones that I always like to think of. So kind of rifampicin, orange discoloration is normal, but hepatitis, enzyme inducer, we need to know that. Isoniazid is probably the most leading one in terms of hepatitis. So when you've started someone on RIPE and they get hepatitis, we generally will not do anything if we'll only stop if the ALT is 5 times the upper limit of normal and they're asymptomatic, or if they're symptomatic and the ALT is 3 times the upper limit of normal. And then you have to kind of just stop one by one and see the response, and then maybe reintroduce, because often it's better fed the second re-exposure. But pyrazinamide is a very good one for gout. And then I think we probably know about ethambutol and optic neuropathy, but levo and moxifloxacin as quinolones, tendon rupture, valve regurgitation, aneurysm breakdowns, and then we've got some of these other ones which you can read about. But these secondary agents will often be given as part of a TB kind of MDT. So for meningitis then, what is meningitis? Well, we've probably all seen it. It's inflammation of the meninges. It's a pathological diagnosis, which we kind of infer with signs of meningism. The important thing is that the average district general hospital sees about less than 10 cases per year. Average incidence about 100,000. But the cause of the meningitis is really dependent on lots of different factors. So the age, the comorbidities, the social history, and the immune status of the patient. These are important things you need to ask yourself, rather than just saying, yeah, it's a meningitis. So we need to think about the things. So the reason I say, for instance, age is that 10% of the population carry meningococcal, so Neisseria meningitidis, as part of their normal respiratory flora. It's not causing any problems. And sorry, I should say pharyngeal flora. But we know that that carriage rate is higher, for instance, in teenagers. It's about up to maybe a quarter. So that's why we see, for instance, teenagers and university students at higher rates of meningitis, of Neisseria or meningococcal meningitis. And as we can see here, I've just illustrated the different groups that we worry about for different diseases. So if it's a newborn, we're worried about group B strep. Listeria from the mum certainly would be one that I'd be worried about. And then, as you can see, for immunocompromised and things, I would be thinking about listeria as well. The important thing is not to rely on Koenig, sign, and Brzezinski's. First of all, I've seen a whole host of things done as Koenigs and Brzezinski's, which represent nothing like the original signs, but there are actually quite limited use. And the sensitivity is poor, probably because of how they're performed. But if you see someone with a particular rash and they're giving you signs of headache, photophobia, and meningism, there's a very good chance that this is going to be meningococcus. So that is something to obviously take away. And as you can see from the history, different things make us think of different causes of the of the meningitis. So if they've got skull fracture, I would think of pneumococcus, because it's usually come from your normal flora of your kind of nose and throat. Or if you've got a shunt infection, kind of less virulent causes, but that would include Pseudomonas. So we would change how we treat. Now, in terms of the diagnostics, and I just want to make this clear, is that you'll often see people have CT heads before LP. There is no good reason on earth why the patient should have a CT before the LP at all, unless you've got the GCS is less than 12, which often it's not. Signs of high or raised intracranial pressure. Immunocompromise is a kind of point that I would raise. So if they've got, if you've got somebody who's on high dose rituximab and other things, or the HIV positive, I probably would do the CT first, and then focal neurology. These are the main reasons with uncontrolled seizures why I would do the CT before the LP. Otherwise, what you want to rapidly do is get the lumbar puncture and get some blood cultures. Because if you do blood cultures, the yield can be about 75%. So really, really helpful. So when we do the lumbar puncture, we can send it off the routine things, including a CSF lactate if your hospital does it, and a PCR. The PCR will often do kind of meningococcal and pneumococcal PCRs, and they can type it, so they can tell you which group of meningococcal is causing it. But they can also test for viral meningitis causes, which are things that obviously we should think about. What I will say is that if you give antibiotics, sterilization of the CSF can take place very quickly. So if the question is, well, he's had antibiotics, so should we do the LP? The question is almost certainly yes, you should, because that's why we do the PCRs. even though you've killed the bacteria, or we hope you have, isn't it? And this breaking of those encapsulated bacteria, we'll be able to pick up the genetic material. So there's no good reason to not do the LP, unless, of course, you've got other reasons. So they're profoundly coagulopathic, they've got active infection around the site that you want to do it, their platelets are, for instance, in the boots less than 50. And these investigations on the right are kind of routine things that can be done if you can't, well, in general, but if you can't do the LP. So, for instance, well, should be done in addition to. So blood cultures, definitely. Meningococcal, pneumococcal PCR from the blood. Serology, the reason I mention that is if they've got unusual exposures. So, for instance, have they been abroad? Is there anything that I need to think about? Things, whether that's tick-borne encephalitis, which can cause meningitis, do I need to be thinking about things? Which you can discuss with paired glucose, obviously. Posterior nasopharyngeal swabs is particularly there to look for Neisseria meningitidis, so we can look for that. I would do a panviral PCR because enterovirus is the most common cause of viral meningitis there is, so we can pick that up and pick other ones. HIV I've put in red because all patients with meningitis and encephalitis should have a HIV test. That is written in almost all guidelines. Don't forget, obviously, the HIV can present as meningitis in acute illness and primary disease, syphilis, and pneumococcal antigen, except for in children, because it's nearly all, it could be positive there when they're asymptomatic and complete well. And enterovirus PCR, because from the stool, because often when the swab is negative from the throat, it's actually positive because the virus is traveling through your gut in the stool. So it could be a nice way to diagnose. And these are the characteristics. I'm not going to focus on this because you're all pretty much aware of this. I just want to make sure, make clear that obviously about the CSF pressures. These are the kind of usual things. The thing I will say is that in early bacterial infection, you can have lymphocytic predominant. So that's not a no to it being a bacterial infection. Likewise, in early viral meningitis, you can have polymorphonuclear, so neutrophilic, pleocytosis of the CSF. And then, things with TB is classically lymphocytic anyway, with very marked proteins. So usually way over it's not uncommon to see up to a gram, for instance. And then fungal, you should be calling for help because that's not a good sign at all. But this is why I was talking about specialist things, because we need to think about, TB meningitis, if it's chronic, it's been going on. And chronic meningitis is defined as kind of over 28 days. Generally, as a rule of thumb, the things I think about are TB, Lyme, what's the TB, Lyme, oh God, what do you call it? Sarcoidosis, and there's another one which I'll come and think of, but these are the ones that will be happening over kind of 28 days. Always for these patients, a travel history. So these are kind of common things. So Toscana virus. So this is a viral meningitis, which you find in Italy and kind of in Europe, spread by sandflies. So not uncommon. Tick-borne encephalitis. I mentioned that because that causes encephalitis, but can cause meningitis and can be spread by ticks, as you can imagine, but also by food. If anyone's interested, I've published a recent review on it. West Nile virus, which is throughout Europe, and you can see here on the map the yellow, so it's throughout. So West Nile virus will happily cause that. And then depending where you've been, we think of other things. Now I put Africa and N meningitidis because they have the meningitis A belt. So the Men A belt is across sub-Saharan Africa. So if they come from Africa and they've, that would be something you would think, have they been in the Men A belt? We need to do it. Rarer causes are things like this. So kind of leptospirosis that we mentioned, Naegleria, that is rare. And if you've got it, the patient is almost certainly going to die. But this you'd be suspicious if somebody's had, for instance, freshwater exposure in either kind of Pakistan, Bangladesh, or in the Great Lakes of the US, and they tell you that it's rapidly declining, not responding to treatment, in which case you do a wet prep, which is where you basically look under the microscope and you will see actually swimming parasite, but they're not going to do well. And if you've got psychosis, very early on features autoimmune kind of diseases and autoimmune encephalitis. So for the treatment, key things, if you give BEMPEN to the patient before they've come in, that hasn't removed their carriage of meningococcal meningitis. So they still need treatment for that, if you see what I mean. So even if you treat them for BEMPEN throughout, which you can do, then they would still need clearage with something like ciprofloxacin, which is what you give context for meningococcal meningitis, to clear their carriage from the throat, to stop them getting it again. And for prophylaxis of close contacts, we mean anyone who's had kind of prolonged contact with a patient over the last 7 days. So if you're sharing a room, sharing halls, you know, that kind of thing, it doesn't need to necessarily mean you're in the same auditorium and they were kind of, you know, in the first row when you were in the back row. Now, in terms of the treatment, we generally give third generation cephalosporin, so ceftriaxone. And even though everyone thinks that they get in really well into the CNS, it actually really doesn't. A pitiful amount gets in. So that's why we give the BD dosing. And, you know, we may need to add in extra things. So when we think about pneumococcal, so ceftriaxone will cover for Neisseria meningococcus, Neisseria meningitidis, will cover for strep pneumo, cover for strep A galacti, so group B strep, and Haemophilus. But if you've come from areas where there's penicillin resistance for your pneumococcus, so that includes areas of Europe, including Spain. I say Spain because nearly 90% of their things, their pneumococcus are resistant. If you give them amoxicillin, for instance, for a cap, you won't touch it. Then we would add in things like vancomycin, and amoxicillin is what you want to add in for listeria coverage. Yeah. The only other treatment that will cover for that realistically out of these, ceftriaxone does not cover for listeria. It would be things like meropenem and rarely chloramphenicol. But if you use that, we're in dire straits. Dexamethasone I've written because you should start empirical dexamethasone while you're awaiting the results. So unless you've got clear purpura and you've seen signs of DIC and you think that this is Neisseria meningitidis, you might not want to give the dex. That's different. But generally what we do is we wait and we can give dexamethasone where, particularly in pneumococcal, it reduces morbidity kind of considerably with regards to kind of deafness and things like that. And we usually give it kind of 10 to 20 minutes before their first dose of the antibiotic. Now, the important thing I've said here is deal with source and assess the complications. So if they've got things like pneumococcal lives in your throat, lives in your sinuses, upper airways. So check, have they got things like sinusitis? Have they got ear infection? If you give, it doesn't matter how much antibiotics you give. And the last patient I saw with really bad pneumococcal meningitis, she was pretty much moribund because she had pansinusitis and they had about 100 mils of pus in all of her sinuses. So unless you drain that and get source control, she ain't going to really get better and your patient won't. So check for where it could have come from, check for the complications. So have they got joints that are infected? Because you get septic joints. If they got DIC and purpuric lesions, these are very useful. Or do they have pneumonia, for instance, which you can get obviously with meningococcus pneumonia as well. And these are the durations of the therapy. So for Neisseria, you can give 7 days. That's not a problem. You can even give 5, but we will extend 7 days, certainly if they've taken a bit of time to settle. But as you can see here, you can give up to 21 days for things like listeria. And you should be suspicious of listeria, as I said, in immunocompromised people, so diabetics, alcoholics, people who are on kind of inhibitors, and they've got particularly brainstem signs. That's always a good little hint, or pregnancy. And then in terms of viral meningitis, the important thing is there is no treatment. We don't give treatment. Do not give acyclovir. Acyclovir does nothing. Even for kind of HSV. HSV causes more of encephalitis, but that's why your guidelines often say Keftri and acyclovir, because often there's a mixture of meningoencephalitis or encephalitis, in which case we're covering for that. Now, one thing I've said is that you can get recurrent viral meningitis, which is called Mollaret syndrome, and this is linked with HSV2. And if that comes up, you don't give anything for that in terms of prophylaxis or any kind of IV acyclovir. It's benign and it will end on its own. That being said, it can be very distressing to the patient. So it's always something to remember. And as I said, prophylaxis is important because we don't want to affect other people. Now, in terms of IPC, if you've got somebody with Neisseria meningitidis and things like that, you want droplet precautions. So you want the patient in a side room, and only until they've had 24 hours of effective therapy can they come out, because then we should have cleared them if they're on things like cephalosporins. If they're only on benpen, you're not clearing it from their throat. So if they're coughing, they're going to give it to you. For encephalitis, then, this is slightly different. So the meningitis, usually a meningitis patient doesn't really have much of a decreased GCS. Encephalitis, we've got an abnormal mental state. So decreased cognition, decreased GCS, bizarre behavior, maybe psychosis. And there's lots of different things to consider. So it could be viral. Viral are the commonest by far, and we're going to talk about HSV being very much the cause for a lot of encephalitis. That's why we say to give empirical acyclovir, but bacteria, certainly with Listeria Lyme, Brucella and Q for rare bacterial, parasitic, which we're not going to focus on too much, but non-infectious, autoimmune and post-vaccination. I say post-vaccination because it's not unheard of with your kind of acute disseminated encephalomyelitis, so measles vaccine, all these type of things. So what we think about is the epidemiology and exposure. So you can start your acyclovir because that is something that will only have activity realistically for HSV and VZV. And if you give acyclovir, you can pretty much half the chance of dying. Although even with people with HSV encephalitis who then are given treatment, and their mortality probably drops to around kind of 10 to 20%, their risks of long-term neurological sequelae are still kind of over 50% in those patients. So they have a really, really bad time of it. And a classical symptom of these patients is kind of anomia. So they have problems naming things and with speech. They can't really, so if you soon have patients with aphasia, HSV is up there, and we'll talk about what you do. But in terms of wider things, you want to think about, have they had exposures to vectors? So sandflies we've talked about in terms of, for instance, Toscana.
Sorry to interrupt, just wary that we're a bit over time slightly.
Oh yeah.
I don't know if we could, do you want to finish up encephalitis and then just maybe show the slides so that people can sort of look at it later for the endocarditis? And then we can sort of wrap up with a bit of the last thing on Hep B and then sort of finish from there.
Yep, sorry about that, guys. Sorry.
Okay.
So these are just some things that I think about worldwide. So, you know, I've mentioned things that are probably a bit rare, but not unusual. So rabies does cause 40,000 deaths every year. Get it from lots of different animals, not just dogs, bats. And so we do have rabies in the UK. So that will cause things. So you need to just balance it to where they've been and what exposures they may have had. So if they've come from an endemic area, these are some of the things that you would think of. And then you can find high risk activities. So as I said, recent vaccination would make me think, could they be having a autoimmune reaction to this? Sexual contacts, because I'd be worried about things such as HIV, syphilis, and all these type of things. Swimming. And the reason I mention that is because of kind of things, once again, with Naegleria, spelunking, that's for fungal infections such as histo and chickenpox exposure. So have they had a recent flare, you know, tip of the nose, anything like that, eye problems, and then it comes there. So that's for that. And then these are just some pictures and some things to think. So what findings will make you think of what type of encephalitis? So as you can see, there's a huge myriad of things. Key things are for brainstem involvement, TB, listeria, and flaviviruses. So that's your Japanese encephalitis, West Nile's, and psychosis, think autoimmune. And these are different features. So mumps, still very common, and we do see it. This is rickettsial infection, the middle picture, and that's varicella zoster on the bottom. And then investigations, so MRI, as we talked about, and lumbar puncture, because the gold standard is a brain biopsy, but we can't do that. So we do this, MRIs and lumbar punctures. So do that and think about sending for these other things, common things, EBV, CMV. And this is HSV, classical temporal findings, which are unilateral, usually affecting the medial temporal lobe. So if you see that, the jobs are good, and the treatment will be about 21 days with repeat LP to show that you've cleared it. This is the kind of treatment and what we should be doing. As I said, acyclovir is only really useful in HSV. It can be used in VZV, but there's no real evidence. And for enteroviruses, which is a broad family, which include things like poliovirus and things, there isn't actually in treatment, but some people do use IVIG, and I have used it once as a kind of last extreme measure. Endocarditis, takeaway points. This is often missed. It's really important to think about it and think about the patient risks. And so that includes, do they have valve replacements? Do they have long lines? Are they immunocompromised? And as you can see from this image from the European, take the blood cultures first. So any patient should be having 2 sets of blood cultures, me, you, anyone. 3 sets for these patients, usually spaced over an hour. Or if you need to, just there and then take them straight. Look for signs of where it could come from. And this is the breakdown of what causes. So fungal is a bad one because then they need lifelong treatment after the acute. And for TAVIs, you think of enterococci, which normally live in your bowel or the bladder and can cause, therefore, infections there. So you need to look for those. In terms of symptoms, fevers are not as common as you would think. So even for prosthetic, it's only about 70 to 80%. And the worrying things would be kind of congestive heart failure, cardiogenic shock, septic shock. So as you can see, septic shock doesn't happen that much. So you have usually time to take blood cultures, get an echo, check for where it could be coming from. And the usual things that we look for in the registry of cases for peripheral stigmata, are very rare. Only 1% will have Osler's nodes in a European registry. And infarcts happen probably way more than we think, up to about a quarter, of which the spleen is the predominant site. So just to say, the diagnostic criteria Dukes has changed as of this year. It's been updated. And so we include different things. Same blood cultures, but we use different modalities now. So you can do cardiac CT, which is better if you've got prosthetic endocarditis, to look for paravalvular problems such as abscesses, fistulas. We can do PET CTs because you might have, for instance, pacemaker infections and things. And also we start using now different types of microbiology, so not just cultures, but PCR and things like that. And these are things that you should think about always doing, checking dentition particularly, because obviously that's where a lot of streps lives, and for bowel symptoms as well. In terms of medical and surgical, the whole point is you don't necessarily need to give 6 weeks of IV treatment. That's the POET trial is a very good evidence of that. So partial oral empirical therapy in endocarditis. So in certain patients, we give treatments now after only 10 days of IV, we give oral, but that's select. The surgical indications at any point are usually heart failure, uncontrolled infection. So that's usually just continued septicemia, a bacteremia despite 7 days of therapy, and emboli. Basically, if the bigger the vegetation over 10 millimeters, the more emboli you have. If you have uncontrolled emboli, we need to get that valve out. But that causes problems. And in terms of antibiotics, it depends on the organism. You can't, going empirically is a risk because you don't know what you're treating. You have no idea it's going to work. And so we give different things based on that. These are the atypicals, which can also be picked up on blood cultures, but through molecular species. So you can do this as part of an atypical screen. Going forward, you want to warn your patients about the risks of re-endocarditis. The valve will be damaged, and there will be a focus for then further attachment because you're bacteremic even just after brushing your teeth. So dental flossing, making sure they keep on top of that, don't have tattoos, and always think about endocarditis with any person with prosthetic material in them. Don't just give antibiotics. This is just a quick thing about hepatitis B because I know people get worried about it. I'll let you look at the table, but the key things I always think about is, are they vaccinated? If they're just out vaccinated, I just expect to see the surface antibodies positive, nothing else. If the surface antigen is very low, I would ask, have they recently been vaccinated? Because that's what the vaccine is. So it'll give a transient rise in the surface antigen before the antibody is present. If it's past or present infection, I'm looking again if they're positive in various markers, particularly the core and the surface antibody with a negative surface antigen. And with that, then could they reactivate? Because even if you've got signs of past infection, it's not eradicated from the body. It just means once it gets into the blood, you clear it. So if you immunosuppress them, it could reactivate. And then we look at the stage of infection. If the E antigen is positive, they're very infectious. We're worried about them. They're more likely to go further in terms of hepatitis and fibrosis. So therefore, we might think about treatment depending on the ALT, which is not always raised, as you can see from the different stages, and the degree of fibrosis, not just the viral load. And these are just some lesions for you to think about, to look at. Erythema nodorsum, I'm sure you all know lots of things, including streps and TB and all the Yersinia and all the rest of it. This is secondary syphilis, which can cause this lovely maculopapular rash. Otherwise, you'd think of things like enteroviruses. This is erythema multiforme, not commonly seen with HSV and things with mycoplasma. This is scabies. So if you see it in the gutters and it's going up with kind of pruritic lesions, and you can do a very good test of just putting ink on them to look for the burrows. This is chickenpox, clusters of vesicles, which then scab. And remember, when they scab and crust, they're no longer infectious. And this is a chancre for syphilis. So while you may expect to see it on the penis and things like that, you can easily see it on there. And the key hint is that it's clean base, a little bit shiny, and there's no real raised margin to it. I'm sorry it's taken so long, but I hope that was useful. If there's any questions, I'm happy to answer them.
Thanks very much, Dom. That was very, very good. Yeah, we have a question from, let's go for it if you want to answer it.
Yeah, so the question is, it depends on the cause. So certainly if you have somebody who's got HSV encephalitis, you do need the repeat LP. The reason is what we're looking for is that the white